Okay, welcome everybody. Spring is here. Lots of new things. I'm in a brand new building that I just moved into. My first day today. I have new anti-reflective glasses and a paid-for haircut. So all sorts of good things happening. And I want to welcome everyone to our what is now monthly COVID-19 in Children seminar series. The text code is there with the phone number, and that will be in the chat. We are doing these monthly open forums now. We'll have probably a lot of recurring guests, maybe sometimes some new ones. We welcome back today two folks that are well known to all of you, and I really want to just take a second to thank both of them for being frequent guests on our show and for doing so much for COVID in children in general. So Dr. Arvin and Dr. Yvonne Maldonado, both of whose titles you can see here and we've introduced many times. Also want to thank my co-host, Roshni Mathew, who is on service today. So we are grateful to have her. Today's session, we will be and we had some pre-submissions, and we'll try to answer all of those questions. We also welcome additional questions into the Q&A function. I prefer to have them go there rather than the chat. And then we also will be breaking down the first part of this. We'll begin with Dr. Mathew doing a quick overview of the local and national epidemiology and sort of vaccination rates, and then Dr. Arvin will provide us. She is a world-renowned virologist and will provide us with a little bit of an overview on the variants, what it means to be a variant, and what we're seeing. And then Dr. Maldonado will tell us about immunizations and some exciting news about local immunization study that we'll be launching here on Monday. And then the last half, hopefully, will be some Q&A that will be open to everybody. So Roshni, why don't you take it from here?
Thank you, Alan. So I figured I would start with some epi information like we did last time. This is from the American Academy of Pediatrics. Children represent 13% of the total cases. That's over 3 million out of 25 million cases in the United States. In terms of hospitalizations, again, reassuring overall, children represent 1.3 to 3.1% of total reported hospitalizations, and a range of 0.1 to 2% of all children with COVID-19 require hospitalizations. In terms of mortality, again, overall reassuring for children. Children represent 0 to 0.19% of all COVID-19 deaths, and 0 to 0.03% of all children with COVID-19 ended up dying from it. This is the CDC's cases by age group. And as previously mentioned, about 13% of the patients are in the 0 to 18 years of age. And so the majority of the persons with COVID-19 are in the middle age group of between 18 and 65. And 65 and over also represent about 13 to 14% of the cases. But you can see when we look at deaths by age group, how disproportionately impacted over 65 years of age are. This is the total COVID-19 7-day moving average across the United States. And you can see on top the aggregate across all of the states. And you can see the numbers have plateaued. So they are about where we were in the summer. And you can see there are some states where they did go up again. So we are yet to see how this trend continues. This is the local Bay Area statistics. And again, all the right-hand side basically shows the different counties and the number of cases in all of them. And the highest has been Santa Clara County. The numbers have trended down and have plateaued over the past several weeks. A little bit about vaccinations. This slide shows the overall vaccination rates across the country. On top, you can see that in terms of percentage of population out of the 300 million population in the United States, people who have received at least one vaccine amount to about 32.6%, and about 19% of the whole population have been fully vaccinated. And this shows us where we land in terms of ranked from 1 to 50. The ranks, although we are about 40th in rank, it's over very minor differences between the different states. So in California, about 34% of the persons in California have received at least one vaccine. And this is total population. So it's not just the ones that are eligible for vaccination. And in terms of population, obviously, California has the highest population. And so we do rank #1 in terms of total numbers that we have vaccinated in California. Out of 39 million, 13 million people in California have received at least one vaccine, and 7 million have received both or are fully vaccinated. If they got J&J, they would have gotten only one. And this is California, this is the Santa Clara County, and about 41% have received at least one dose, and 24% have received both, have completed their vaccination. That was my slides, and I'm going to share for Dr. Arvin.
So I have just 4 slides. Alan and Roshni asked me to talk about the variants, and so this is right from the CDC website on variants. You can see it's the latest data covering January 2nd to March 13th, circulation of the different strains. And I've marked with the asterisks the variants of concern. And those are 1, 2, 3, 4, 5 that you can see there. Starting from the top, the most common is the 1.1.7, as we know. Then moving next, it's 1.429 and 1.427, which, as you can see, those are grouped together. And so in California, that is 56.1, grouping both of those. And 10% of 1.1.7 in California right now. If you look at P1 down at the bottom, it's 0.7 in California and 0.3 to 0.8 nationally. And then 351, which is the South Africa variant, is 0.1 in California and 0.3 and 0.7. So those two are really quite low at this point, but they have been reported at least once in quite a number of states to date. So then if we go to the next slide, please. This is the data that Ben Pinsky gave me from his summary earlier, actually yesterday, I guess. In any case, you can see that this isn't a denominator, this is numbers, but you can see if you look under variants, you can see which ones are being detected by our lab. And as you know, the lab is providing state-of-the-art information on the positives that we're getting at Stanford, thanks to Ben and his team. So you can see that the 1.1.7 is there. Very few of the South Africa variant. The 427, 429, as I mentioned, though that's the California variant. And so naturally we have that. I forgot to mention the 1.1.7 is one that emerged most prominently first in the UK. So 2 slides now on the question of the relevance of the circulation of these variants to vaccination. And so this is data which is, again, from the CDC. You'll see this table has references, and if you go to that site that I've shown there, you'll find the references. But what I will say about this table is 1.1.7 has been tested. That is to say, sera from people who've gotten one of those 4 vaccines on the right, their sera has been tested for ability to neutralize that variant. And as you can see, there's minimal impact regardless of which vaccine is given. The P1 has been tested with post-vaccination sera from people who got Moderna, and there's some reduction in neutralization. 1.351 has been tested against the 4 vaccines that I've shown there, and there is a moderate reduction in neutralization in post-vaccination sera. 427 and 429 have been looked at for Pfizer and Moderna in one study, and you can see a moderate reduction. So I would point out a couple of things here. Each one of these studies is based on a very limited number of sera that were tested from people post-vaccination. And as you can see, the 117, which is quite common now, there's really minimal impact. There is some reduction in neutralization activity against the other variants. That is compared to what is seen in the, if you're testing as was done in the same assay against the original virus before the mutations appeared. So next slide. This is the last slide I have, and what I really want to stress here, and I hope that you've known this for your own reading, but the mistake that I see being made constantly, including on the front page of the New York Times today, the presentation of circulation of these variants without saying whether or not we can expect vaccine production. And there is a couple to that. There is a very common tendency to say if there's reduced neutralizing antibody in one of these assays, that means there will be reduced vaccine protection. That is not the case. And so what we need to really communicate is that the relative decreases in neutralizing antibody titers that we are documented, reported against variants, doesn't mean that those titers are below a threshold that you would need to see a clinical effect. And so the other thing I would say is to be aware of what these neutralizing antibody assays actually are. And they're done, as you probably know, with pseudoviruses. And they're also, in some cases, done with the actual viruses. In any case, they're typically done with a cell line that's expressing the ACE2 receptor at high concentrations in order to be able to measure the neutralizing antibody effect. So I'm trying to convey it's quite an artificial system. That doesn't mean it isn't relevant, highly relevant for vaccine evaluation, but it is not a correlation. A lower activity does not correlate with what's going to happen with the vaccine protection. And there's just a couple of bullet points there about the Pfizer data against 351 and the Moderna data against 351. Yes, there's less neutralization, but compared to what one might expect to have benefit, it's the case that those subjects did have neutralizing antibody in a range that one could expect some benefit. The other thing I would say is, it's not on the slide, but antibodies have various functions, not just neutralizing antibodies. And so we have to remember that the antibodies that are detected by neutralization are not detecting the antibodies that work necessarily in antibody-dependent cytotoxicity, the other mechanisms that antibodies use, that we use our antibodies to protect ourselves. So that is one measure. The other thing that, of course, is not being measured here is the memory T cell responses. The memory T cell responses are capable of recognizing many epitopes on the spike protein, and that is regardless of whether there's a variant in the sequence there or not. So I think it's really important to know the context of what's being measured with these assays. At this point, we really don't have much clinical information about post-vaccination protection against the variants, but we do know, for example, the J&J vaccine has overall 85% protection, including against 351. And the typical pattern is protection against severe disease. So even if we see breakthrough infection, we know that many vaccines provide great benefit simply by reducing severity. And that is another point that I think we need to concentrate on. Finally, if we don't vaccinate, we are simply going to have more and more variants. I think everyone understands that. So the bottom line is, I really hope we can convey a message of vaccine confidence. That's what we should be talking about at this point in time. Thanks.
Dr. Arvin, you're always so reassuring. So I think.
Well, okay, let's say vigilance is required,
Vigilance,
and certainly the deployment of better and more sequencing of what's being identified in people, whether symptomatic or asymptomatic vaccine recipients or not. We have to have that data. But right now, we have a fantastic opportunity to really have a very big impact. And I think we're all very pleased to see how the vaccines are being deployed. I mean, 3 million doses a day is fantastic.
Yeah. And I think, you know, when we had you on before, you weren't at all surprised that we were seeing these variants. Has there been anything that has surprised you about kind of their behavior thus far?
Well, let's see. I don't think so. What did you say? What it's like to be a variant? You know, I think Bonnie can help us with this for sure. But certainly, you know, there is data looking at transmission, and maybe these variants are acquiring ability to transmit more efficiently. That certainly looks like that's the case for the UK variant. You know, the South African variant in South Africa, I think we may have talked before, it caused an outbreak and then it subsided. So it's, I think we are all very dependent on the best molecular epidemiology we can get here. And that really is important to continue. But as far as surprises, I mean, we all hoped that this virus would be more like the common cold coronaviruses and not show this level of mutation in the entry protein. Obviously, that is not how it's playing out. But you know, I think we just need to realize the very, very important benefits of vaccine here. And I worry that there's all the talk about the variants may be having a chilling effect on people realizing that the vaccines will benefit them. And as the president said, it's a public duty to get vaccinated here.
I could say something. So one of the things that is a little bit surprising about the variants to me, two things. One is we knew that this virus, actually from the beginning, Anne knows this, obviously, that it has a self-correcting mechanism in it. So it is supposed to have a reduced mutation rate, actually. So we know that RNA viruses mutate faster than DNA viruses. But this particular virus was supposed to have a self-correcting ability to eliminate some of those mutants. And even with that, we saw this tremendous degree of mutation that I think reflects more than anything, just more transmission. And one of the other thoughts that we have, there have been a few papers, one in Nature Medicine and others, just looking at some of our colleagues' experiences in South Africa, for example, that there may be populations where the virus just amplifies faster, for example, in immune compromised patients. And we are seeing that the rate goes up at a certain steady rate, which we expect. And then you see this quantum leap in a population, and then it continues at the same rate. So you may have spoken about this last time, Anne, but the fact is that there may be some, I hate to use the term super spreader because that's not a virologic term, but there may be populations where the virus actually just is allowed to replicate faster. So if the rate is the same, but you just do it faster, you're going to get more mutants. So that's one surprise. The other surprise is that when I spoke to my colleagues in South Africa back in September, we didn't know about the variants, obviously, but they said, we're just seeing a lot of people getting infected, but they're not getting that sick. They're actually pretty healthy, but where the rates are high and it's different from everywhere else in the world. And of course, Johannesburg has world-class virology labs. And so they started to sequence the viruses and they found that they were starting to see these mutants. And so, and I followed up with them a month and a half ago, and they're still not seeing severe disease from this particular mutant. So the bottom line, and maybe Anne knows, is we just don't understand the functionality of these mutations. And that's critical for us to understand. In fact, we don't know anything about what this virus, how this virus really does what it does. And I think that's key.
Well, I think that's true, because remember, a lot of these viruses have several mutations, and so that there's a potential for combination effects, and it's very hard. Molecular virology tools exist, and we can make viruses that would have various combinations of these mutations, pseudoviruses. But it's really hard to recapitulate in an in vitro system what is actually happening in a person. And I think we knew from the in vitro systems that, like any respiratory virus that depends on fusion, there will be mutations in an in vitro system. You can create those mutations by selective pressure with different antibodies. So as Bonnie said, the rate of mutations we had hoped might be a little bit less based on the biology of coronaviruses. And, we still don't know what a steady state is going to look like here. I think that's another question, but I think the point that you made that's really important, and it tracks back to whether the vaccines are going to protect or not, is the force of infection. And so if you have very many people in very close quarters and they have high viral loads, then the virus doesn't really have to work too hard to transmit. But if you have vaccine immunity and you're not having a close exposure, you're having a casual, maybe 100 PFU of infectious virus gets into your upper airway, that is going to be a different outcome, likely, just simply allowing the immune response more time to deal with it, and especially if you already have vaccine immunity. So the culture systems where we look at neutralization, it's really set up to maximize identifying a difference from the original virus. And that isn't necessarily at all what's going to happen in somebody who's immunized and who may have an exposure to one of these viruses that has been more readily transmitted. So we have to keep on thinking the virus has got to find an ACE2 positive cell after it gets inoculated into your respiratory tract. If you put it in a tissue culture plate where every cell is expressing ACE2, that's not quite the same setup.
Well, there are a bunch of questions coming in. I think maybe Dr. Maldonado, if you want to just run through your slides on vaccination, which has a lot of overlap with what we've talked about, and I think with some of the questions, and then we can sort of pick and choose what's left after that.
Okay, there we go. Yeah, let me just go through a couple things because I have some really interesting updates just around public health and what's going to be happening. I think all of you have heard some of this, but I want to make sure everybody's on the same page. So just to remind everybody that tomorrow there's a Department of Pediatrics COVID updates town hall around education, research. We're going to hear about the CAM building, I hope. And then Roshni and I will talk a little bit about just some issues around what we expect we'll be doing around masking and distancing, given the governor's new announcement that we are opening up more in June if we continue on this positive trend. So I know there's a lot of words here. We'll share the slides with you later. But I just wanted everybody to know that last week, the CDC updated their travel guidance that people who are fully vaccinated can actually travel around the US without having to worry about testing or isolating. However, they will have to obviously still wear a mask and distance and avoid crowds, et cetera. And I think it was really, the data has been more and more available around how safe these vaccines are and how effective they are. So I think this is another addition to what Anne said about making sure that hopefully this is an encouragement for people to get vaccinated. However, around international travel, because of the issue around variants and for other issues as well, well, they say that the variants are an issue, but frankly, just looking at what's going on at the university level, some of us are concerned that given the surges that are happening in other places, we also do worry about the ability of people to get adequate healthcare services in general if you're visiting an international site, given that they're so busy now with COVID. Also, I want people to remember that in international travel, there are some restrictions around insurance and travel policies that if you need to be evacuated for whatever reason, say you broke your leg or I don't know, whatever reason, you need to come back or go to another site for care, some policies will not allow, they will not transport people who are COVID positive, even if they're asymptomatic. So you just need to check if you're going somewhere that your insurance policy covers travel if you're COVID positive. Hopefully you're not, but you know, again, we just want to make sure people are aware. So fully vaccinated people can travel internationally without getting a test. They don't need to self-quarantine when they come back unless it's required. Now, just so you know that here in Santa Clara County, they have not changed to this guidance. So you have to remember that the local county always dictates what you need to do. So at this time, Santa Clara County is still requiring testing and, well, you don't need the test to test, but if you test, you can come out of quarantine more quickly than if you decide to just wait and self-isolate after you travel. But you should have a negative COVID test when you get back on a flight to the US, however. And then this is just the links that I'm going to share with Alan, so that if you want to look on the CDC website, there's more information about the travel restrictions and the travel opening. Now, this is just to follow up with Anne's slide. If anybody wants a link to the CDC website, it tells you how many variants, the major variants. It doesn't give you a lot of information, but at least it starts to give you some snapshot of what we're seeing across the US around the variants and what states have more variants. And again, I don't think we have to worry about the numbers so much because it really has to do with how many labs are actually looking at sequencing what they have, what viruses they have. So you can see that B117 is the most common, and it's actually leading the surge in Michigan, Illinois, and to a certain extent in Minnesota as well. And then remember, we have the 3 vaccines licensed in the US right now: Pfizer, Moderna, Johnson & Johnson. We've seen between 30 and 40, almost 45,000 people enrolled in each of these trials. Just to remind you, again, any vaccine is great, even though the Johnson & Johnson vaccine looks like it's not as good, with 66% efficacy compared to 94 and 95% efficacy for Pfizer and Moderna. They are all 100% effective still at preventing hospitalizations and deaths. So if you did happen to be infected with Johnson & Johnson at a slightly higher rate, you would be very unlikely to have severe symptoms and moderate symptoms. And The way Johnson & Johnson defined moderate symptoms is almost equivalent to the way Pfizer and Moderna define mild to moderate. So these would not be severe symptoms at all. And the risks are extremely low in low prevalence areas, as we know. This is a slide that shows what's the real world impact of the vaccine. So this is a study that came out, I think, a couple weeks ago now, looking at almost 4,000 individuals. These were first line responders and healthcare workers in the US, and they were tested daily for 13 weeks by PCR during normal working conditions after they had either not been vaccinated, had received 1 dose of vaccine, either Pfizer or Moderna, or 2 doses of Pfizer or Moderna. And the really good news here is that among the unvaccinated people in that 13-week period from December to March, there were 161 SARS-CoV-2 infections in the unvaccinated group, 8 cases in the partially immunized group, and 3 cases in the fully immunized group. So that led to what we call a vaccine effectiveness rate of 90% among people who'd been fully vaccinated and 80% among people who'd gotten just 1 dose. So this is real world data. This is not a clinical trial. This means that, and the vast majority of those cases in the vaccinated, either partial or full, were asymptomatic. So this is very good news around the safety and efficacy and effectiveness of these vaccines. Now, I'll just stop. I have 2 last slides here talking about the Pfizer vaccine. And we know that they started their clinical trials in July for for adults primarily, but then they started recruiting participants age 12 and over in small numbers in July, and then really ramped up those numbers of younger people in the fall, so that by this recent article you see from last week in the New York Times, about 2,300 participants were between the ages of 12 to 15, and 754 were between 16 and 17. So actually more young adolescents than older adolescents, or preteen and adolescents. And the data, they didn't give data, this was a press release, but the interim analysis demonstrated very good safety reports and very robust immune responses. In fact, the 12 to 15-year-olds had higher antibody responses compared to the adults, and 100% effectiveness against symptomatic infection with 0 cases in the vaccinees, compared to, can't read it because the little thing at the bottom is blocking my way there, 18 cases in the placebo group. So very effective and very safe in that age group. And it's very likely that these vaccines are going to be, the Pfizer vaccine will be submitted to the FDA for EUA consideration, I'm hoping by this month. There won't be a full meeting because this will just be an add-on to the existing EUA. So we're hoping that soon we'll have an indication for 12 to 15-year-olds. And we also expect that Moderna will be submitting data for an add-on to their EUA for 16 to 17-year-olds, and then an add-on for 12 to 15-year-olds. So we're hoping that by this summer, there will be at least 2 vaccines available for children as young as 12 years of age. Certainly, the American Academy of Pediatrics has been really pushing the company and the federal government to make sure that we have vaccines for kids, especially in the adolescent age group, because the adolescent immunization platform overall is really the poorest compliance so far, given the drop in vaccinations in the last year. We really need to get our adolescents caught up, as well as all our other age groups, but especially the adolescents. And we particularly want to make sure that we don't interfere with the flu vaccine schedules that will start in the fall. So we really want to make sure that we can get our adolescents vaccinated. Now, regarding the younger age groups, Pfizer has started in March to dose healthy children in global phase 1, 2, and 3 studies. And we at Stanford were recruited to be part of the phase 3 5 to 12-year-old study. And we are planning to start that in another several weeks. There are sites that are already enrolling, but that we were asked as part of a 5-site study group to start phase 1 trials in children 6 months to 2 years of age. So the company has already started vaccinating for dose finding, meaning looking for the safest and most immunogenic dose in kids 2 to 5 years of age. And we are going to start on Monday, we hope, to vaccinating 6 month to 2-year-old children, infants and children, with the lowest doses of vaccine, and then moving up the week later to a higher dose, and then the 3rd week after that, in different cohorts, to the dose that's given to adults. If we see that the vaccines are well tolerated in kids, and then that rolls right in to the phase 2 trials of more children, ultimately enrolling over 5,000 children for the phase 1, 2, 3 studies. So these are going to take some time to get to phase 3 completion, and we're optimistic that these could be done before the end of the calendar year. And whether or not there's an emergency use authorization for these by the end of the year is unclear for the under 5-year-olds. And this is just a slide that I can share with you to have showing that 4 vaccine manufacturers, including AstraZeneca, have already enrolled adolescents and are starting to talk about submitting to the FDA, as I mentioned before. And then, as you saw, we are already looking at Pfizer and Moderna vaccination of younger kids. And I understand that we're also going to be doing here at Stanford some younger child studies for the Johnson & Johnson vaccine as well. So I will, just wanted to mention that if you go to the Pfizer website, there are going to be trials in pregnant women as well. Those have already started. We did not, we were asked, but we did not join those trials, but there will be trials in pregnant women as well, looking primarily at safety. Thank you.
Great overview, Dr. Maldonado. Thank you. There, at the end there, particularly, I think 3 or 4 questions have already rolled in, asking how people can get their children enrolled in these trials. Is there something we can send around? Link?
Yeah. Yeah, I think I'll have to find it again. We do have a registry website set up, and actually I was just on the investigators call yesterday. There's about 5 sites, as I mentioned, that around the country that are enrolling the little ones. And some of the sites have 5,000 people already signed up to try to get their kids into the trial. So we're really excited about this. And when you talk to the media, they're surprised that people want their children to be in these studies, but it just shows you that pediatricians and parents know what's best for their kids. So don't listen to the negative reports out there. These vaccines, we already know that millions of people have been vaccinated and they're very safe. And we know how to do vaccines in pediatrics. It's something that every pediatrician is very familiar with. So I will send you the link later on to the registry.
Yeah, the other thing I think is correct, Bonnie will correct me if it's not, is that the plan for the pediatric studies is to, as she said, do the immune response assessment. And the expectation is that that can be a bridge rather than to have to do, as would be really hard to do, we hope, because we hope to have the numbers way down, but to do a protection study. I think the protection study that she told you about with Pfizer is probably I would guess, one of the few protection studies we'll see, but I believe that the FDA will accept an immune response correlate to what was protective in adults, if that's measured in children. So I hope that will very much shorten the time to approval, or at least EUA for the pediatric population.
Yeah, so we talked to the FDA and CDC, and they're all exactly what you said, Anne. It's just like meningococcal vaccine. I mean, there's just no way you're ever going to do efficacy trials when the number of cases will be low, especially in kids. So immunobridging, even though we don't have an immune correlate, they're going to use whatever the assays are that are comparable in adults to demonstrate that the immune measurements are similar in children compared to adults as the outcome.
Of course,
if they find cases, that will be, that won't be the sine qua non for approval. And actually, by the way, we also understand that the BLA, so if you want to actually get a full approval, that is not going to happen this year. Absolutely. We've heard already, we're all going to be working under emergency use authorization. The BLA data will probably be submitted by the end of the year to the FDA, but they're not going to fast track that. That is going to be the regular longer term consideration. So the reason that's important is not because we're worried about safety. There's just a lot of data around endpoints, around immunity, and what are they measuring again, and what's the duration of immunity. But it's important because you cannot, in order to get somebody to be mandatorily vaccinated, you need to get their consent if it's not a fully approved vaccine. So for people who are mandating vaccines, you're going to need to get consent. You can't mandate an EUA vaccine.
Yeah. I think, though, just isn't this true that, as I understand it, the EUA package, as far as the actual safety and efficacy, is a complete package. And so we should not think that there's pivotal data. The EUA would not have been issued without the full data set. The other thing I was just going to note is the reason why we don't have a correlative protection is actually that the vaccines are so very extraordinarily effective. You have to have breakthrough infections to define what was different about the person's immune response who got infected versus the person who was protected. And we just don't have a cohort of people in the vaccinated group to really pin that down. So that's actually a good thing, but kind of perversely leaves us a little bit in a gray area. Nothing that's going to slow things down, though.
So I think, I'm going to ask a question that we've asked before and that has been submitted for today. And I think the vaccine has been great for adults, in part because adults are high risk. Kids are not as high risk. We have a lot of general pediatricians that are listening today that are going to be having these conversations with families where they're, where they're going to need to convince families that this is highly safe and efficacious for kids. How do we best have that conversation when we get to summer, which it sounds like Dr. Maldonado is when maybe the earliest we would see enrolling the vaccine to 12 to 15-year-olds. The hope would be that prevalence will be considerably lower then. How are we going to emphasize to families that the benefits definitively outweigh the risk?
Yeah, so there's a couple things. First of all, children under 18 make up 85 million people in this country. So that's almost a quarter of our population. If we really want to make sure that we are at herd immunity, whatever that means, it's really hard to measure herd immunity. But if you really want to fully vaccinate our country, or at least get close, you really need to consider people under 18 for population reasons. The second issue is that there was a paper written by one of our colleagues at Children's Mercy looking at the risk of hospitalization and death from influenza, from rubella, from other diseases, measles, before vaccination was available and after. And COVID-19 ranks right up there. We've already had almost 300 deaths from COVID. It's unusual to see 200 deaths in a year from flu. So it's already, even though the risk is, we're used to seeing these thousands and thousands of deaths in adults, but the fact is that's an anomaly. We shouldn't be seeing thousands and thousands of children dying. The fact that we have 300 kids dying from a disease that is potentially preventable is still a problem. And we don't know what the long-term effects of COVID are going to be, infection in children. So there are a number of reasons, and pediatricians obviously will know this, and AAP is certainly messaging this to our pediatric providers. I think tonight there will be a red book asked the Red Book group, which I'm actually the chair, but I can't be on the town hall, but David Kimberlin and others will be on talking to pediatricians about messaging around COVID and vaccines.
Yeah, I just want to echo that because we introduced the varicella vaccine, of course, we were experiencing about 150 deaths a year. That was year in and year out. But that was, oh, sorry. That was enough of an impact considering other pediatric disease burden to say, yes, we need to do this. And it had the desired effect. So I think that we need to message a direct benefit to the children, as Bonnie mentioned. I mean, if I recall the numbers, it's 10,000 or so hospitalizations of kids. And as she also said, what are going to be the longer term effects? We don't know. But even hospitalizations, that's right up there with chickenpox hospitalizations. And so I think it's a direct benefit, but then as we know, if families want to get back to a sort of normal set of interactions, then they will need to think about whether or not the child might be asymptomatically infected if the rest of the household or extended family isn't vaccinated. So we have both the direct and indirect benefit.
Roshni, you're on service. You've been on service quite a bit the last couple of weeks. Any reflections on sort of the burden of COVID in kids that you've seen so far?
We have slowed down, which is great. We haven't had many admissions for COVID. So we went through, during the surge, we did have several hospitalizations for COVID, and then we saw a few MISC cases, but now thankfully we are not seeing either. So we are in keeping with what's happening in the community.
Yeah, and I think, you know, we tend to focus on hospitalization and death and as far as the morbidity, mortality are concerned, but someone wrote a question about long COVID in kids. I don't think we know much about that yet, but certainly the possibility that there are additional long-term ramifications beyond just having been hospitalized and dying is part of that consideration.
Yeah, so Ellen, I don't know if Roshni or anybody, Anne, would like to comment on the Lancet paper. Well, I'm sorry, not the Lancet paper, that was adults. The MISC paper that CDC just published.
Yeah, I think what was striking, I think most striking about that, if we're thinking about the same one, was that most kids that develop MISC did not have initial symptoms. And that has certainly been our clinical experience as well. Thankfully, still MISC has been reasonably rare, considering you know, the number of cases that we think we've had in kids over the course of the country. So it's still been pretty rare, but we've had one incredibly sick kid in the PICU a couple of weeks ago, and a number. I think we've had, Roshni, what is it, about 12 or 14 total. Yeah. So probably half have been in the ICU. So it's certainly nothing to scoff at.
Let me just make a couple. Sorry. So two things that really struck me. I mean, this was not new data because basically it was just larger numbers of their registry. But two things that really were striking to me. One is that, and this was true from the very beginning, these kids are really sick when they come in. But the survival rate is incredibly high too, given that they almost come right into, as you know, come right into the ICU. 50% of them walked right into the ICU. The second thing is that there's now 3 classes, right? So they've talked about the full-blown MISC, then you've got the acute/MISC, then you've got the mild ones, and the mild ones are the little ones. But conversely, the older kids are the ones who are going to have that long-term cardiac manifestation. So I do, again, coming back to this issue of vaccination, there's something going on here with the pathophysiology that we just don't understand about this disease and how it manifests. Even in kids by age group, there are some real differences.
Yeah, I think it also tracks back to the point, which was also true in varicella. You cannot predict which child is going to get into trouble. And when you're talking to parents, I think, there's a concept, reasonable, that you can just, well, let's just wait and see. If the infection happens, then things will be done after that. That is not a good way to think about it, because it is really unpredictable which child is going to get into trouble. So I think that's another part of the message. I did see a quick question. I glanced at the Q&A about the India variant and the double mutation variant. At this point, I would say that has not reached the variant of concern category. It's at this point not known to have any of the features of those that are variants of concern. Maybe someone else knows more about it, but that's a quick response to that.
Agree. It's just, don't know.
Yeah, and I think Dr. Arvin, there's a few, or Dr. Maldonado, or any of you, there's a few fairly technical questions that have popped up. So some of those we may be able to type the answers to as well. I want to talk, there's a question here and also submitted about vaccinating moms and potentially having immunity to children through breast milk or other passive means. Any information that we know of on that yet?
I don't know of any information, but it's a mechanism that works for every other type of pathogen antibody. I can't imagine that you wouldn't get active transport at the end of pregnancy, and plenty of newborn antibodies waning over the first year of life, and presumably likewise some antibodies in breast milk.
So, we are actually involved right now with a Pfizer RSV vaccine trial. We're giving, and actually Natalie Aziz is leading that study with us. And we've been now vaccinating pregnant women later on in their pregnancy against RSV. And the idea is really to protect not only the mother, but primarily the baby. Unfortunately, or fortunately, we didn't have an RSV season, so that study's being extended another year. But again, the same issue that Anne brought up, the concept is the same, that you can protect those newborns. And it may be that you don't need to go below 6 months of age with the vaccine if there is protection from maternal vaccination.
Yeah.
I wanted to ask a question. Dr. Maldonado, you've talked about equity in vaccination a lot. I wanted to just get a sense from you as to how we're doing on that front. Are there things that we could be advocating for? I mean, it seems to me that it's hard to find a vaccine right now in terms of if you haven't met the whatever the current qualifications are, but people are finding them if they're looking really hard. But our most vulnerable populations, I think, aren't able to do that. Any thoughts on how we are doing from a vaccine equity perspective?
Well, that's been a major concern from the beginning. We know the populations that are at highest risk are people who have, are sociodemographically challenged. So these are people, and we've been working in these communities for a long time. We set up the East San Jose roller rink vaccination site. It's really fun to see a big vaccine clinic in an old roller rink that's all decorated. It was very exciting, but virtually nobody who was in that line spoke English. It was Asian populations and Hispanic populations, and they were so excited to be vaccinated. But you had to go to their community because a lot of these people work 2-3 jobs. They don't have cars. That's the best way they can get there is walking or maybe catching a bus over. We need to, and so a lot of us are trying to message to the minority populations or the lower socioeconomic populations, because if you overlay the map of social vulnerability by census tract with the map of COVID cases, they match exactly. So the cases are happening in those populations, and there's a reason. It's not because of their race or their ethnicity. It's because they have challenges around poverty and access, even internet access. So getting to those people is really important. And I think we've been focusing on that. There is one frustration that I say people have voiced is that now what we're doing is the state is focusing on the 40 highest risk zip codes. And most of us aren't in those zip codes. And I think people feel like, well, why don't I get my turn? But the reality is those are groups, those 40 zip codes are people who have not had any access to vaccine, 4 or 5 months out from the first licensure. So as more supply is available, we will be able to get to everybody. But right now the focus is on getting to those groups that have the highest risk for infection. And I think it's starting to work because we are seeing an overall drop in California. But that's really, just like everything else with COVID, we've started to see that inequities have already existed are just being exacerbated. So more vaccine will just be available. As more vaccine is available to everybody, we need to make sure that those groups are identified. And working in global health, we vaccinated away polio type 1 and polio type 2 and polio type 3 by finding every last child. That's the only way you do it. You have to go out and find people. They don't know how to get access. They may not know that they are even eligible.
A question just came in about asking to comment on demographic variation in children with MIS-C, and I think we've certainly seen striking disproportions and disparities there with a much higher prevalence in our Hispanic Latinx population and our Black population. Interestingly, though, not generally healthy kids that have come in, previously healthy kids that have come in with MIS-C. A question came up about I know you guys have seen the concerns about the AstraZeneca vaccine and clots. Any concern about that? Should that make us concerned about any of the other vaccines? Has that affected prevalence, do we think, in Europe?
I don't know, Anne, what you think. Do you have any insights?
No, I was hoping you would.
I have some, but I thought maybe you would. Go ahead. You go first. So, there have been safety signals from the very beginning. Remember, the first trial was the AstraZeneca trial that got started in April. It was the first one out of the chute. And they had to stop first because there was a case of cavernous sinus thrombosis in one of their patients. But it's one case out of the first few people vaccinated, and nobody really, they investigated and they didn't think it was related. And it turns out that in Europe, the EMA, the European Union equivalent of the FDA, did find 33 cases of cavernous sinus thrombosis in women under 50 now who received the vaccine. So, at the same time, they found that and they cleared the vaccine as being safe. So I don't have access to that data. I don't really know what to say about it. There's some literature that's published in medRxiv, so it's not peer reviewed, but there seems to be some indication that some investigators in Norway and Germany have thought that there may be an autoimmune response of some sort, or autoantibody response. It's not clear to me if anybody who has expertise in this area, for example, Kari Nadeau, would weigh in on this, but it's still up in the air. We'll see what happens when they submit their data to the FDA. Boy, that's going to be an interesting meeting, but hard to know without the data in front of us.
Great. Well, good. I was going to say that CW's question, which were a little more on the technical side, it looks like Dr. Arvin or somebody just tried to answer some of those. So it was about adenovirus vaccines and spike proteins. We are out of time, but I want to thank all three of you so much again for joining us and giving us, I think, what has been fairly optimistic, encouraging, inspiring news about vaccination and the variant. So thank you guys so much. We'll see everyone back in May for our recurring monthly session. Thanks so much.
Thank you, Alan. You're always a great moderator.
Yes, thanks so much.
No problem. Bye-bye.
Thanks,
See you all.
everyone.
Bye.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.